It's my pleasure to have my colleague, Dr. Ahmed Abdelwahab, lecturer of internal medicine and nephrology at Mansoura University. In the program you have, the topic was patient-centeredness or patient-centered approach. But because we discussed this issue many times during the last 2 days, so I discussed and interrogated with my colleague Dr. Ahmed this morning to change the topic from patient-centeredness into more practical presentation, which is very important for you, regarding dialytic support for acute renal failure. And today we'll enjoy Dr. Ahmed's presentation. Dr. Ahmed, tafadhal.
First, I would like to welcome our guests from different African countries. Second, I want to thank Dr. Hussein for calling me as his colleague. For calling me a colleague, he is our professor, eminent professor. I would like to honor Dr. Adel. Inshallah, we are going to talk about the dialytic support for acute kidney injury. At first, we know that we have different classifications for acute kidney injury, started by the Rifle classification in 2002, followed by the AKI classification in 2006, and lastly, the KDIGO classification in 2012. They all try to classify the acute kidney injury and to tell us when to consider our patients at risk of acute kidney injury. The risk of acute kidney injury, this article was published in the CJC. They say for every patient who is admitted to hospital, when we admit 100 cases, 20 of these cases will develop acute kidney injury. We know that acute kidney injury represents about 1/3 of the admissions to hospital, and it occurs in about 18% of the patients admitted to hospital due to different causes. From these 20%, 1 or 2% will process to acute kidney injury on dialysis, and 1 or 2 cases will eventually die. So we are facing a great problem. So we have too many questions in our lecture today. What do we aim for? When should we start acute kidney injury renal replacement therapy? Which dialytic modality should we use? Which vascular access? How many sessions or how much therapy should we do to our patients? And when should we stop? Is the treatment going to be finished or not? The ideal renal replacement therapy should allow me to control the intra and the extravascular system volume disorders, correct the acid-base disorders, correct the electrolyte disorders, control the uremia and toxemia, of course promoting renal recovery, promoting survival or improving survival, to be free of complications, because most of our acute kidney injury patients are already with multi-organ system disease. So I don't want to increase the burden of the disease. In some cases, we use renal replacement therapy to clear toxic drugs. So there are some factors which may be obstacles for initiating renal replacement therapy. These factors may be classified according to the patient safety or to the implementation to strategic facilities. To the patient safety, we should inquire if this patient requiring renal replacement therapy, or can I postpone him and his kidneys will recover. And if we decide to do renal replacement therapy, so the complications associated with the catheters, the hypertension and the cardiac events which could occur due to the dialysis, or the renal injury which could follow the renal replacement therapy if there is hemodynamic instability. The other factor is the logistics, which may be not available in every place, in every hospital or in every institute. The availability of inserting a vascular access, or the machines required to do renal replacement therapy, or the dialysate required to start renal replacement therapy, or all of these logistics are available, the trained personnel, doctors and nurses. We start renal replacement therapy in acute kidney injury or chronic kidney disease on different parameters. It's either blood urine nitrogen, creatinine, urine output, the interval between the ICU admission or hospital admission and the onset of acute kidney injury, the severity of acute kidney injury according to which classification we use, the prognostic scoring of all patients on admission to the ICU, or the multiple organ failure or the number of organs affected with the kidney. Is it either the kidney alone, or kidney lung, or kidney lung and heart? They have studied many factors which will determine starting renal replacement therapy. At first it was serum creatinine, too many studies. I just want to point that the parameters to start acute renal replacement therapy for serum creatinine. Some studies refer to 309 micromole. Some studies started with 224. So the limit for serum creatinine to start renal replacement therapy is not fixed. What could be early in one study could be late in another study. The same goes for serum urea. You are going to notice that this study started with 28.6. This one started with 21.4. So this is considered early. This was considered early. So this is considered late for this one. This is started at 35.7. So again, there is no definite number to use to start renal replacement therapy either regarding creatinine or serum urea. In my opinion, if you want to study a factory, you should study its product. And the factory is the kidney, and the product is the urine. So in my opinion, it's the clinical presentation of the patient plus the most important factor, which is urine output. Oliguria or anuria is a definite indicator, of course after excluding post-renal factors, is a definite indicator to start renal replacement therapy. There are two studies were published in the New England Journal of Medicine. The one is the VANI study, published 2008. They started renal replacement therapy at urea 21, volume overload, resistant hyperkalemia, severe metabolic acidosis, and uremic symptoms. Of course, these are all compelling indications to start hemodialysis, but he used serum urea of 21 millimole. Another one, which is the renal study, was published 1 year later, 2009. They added the urine output. The potassium was higher. The previous studies was 6.2. This is 6.5. The acidosis and chlorine nitrogen, they added creatinine to the equation, and of course, clinically significant edema. Pulmonary edema is an inevitable cause to start renal replacement therapy. These are the compelling indications to start renal replacement therapy. And I think there is no debate about these indications when dealing with a patient either with acute kidney injury or acute on top of chronic kidney disease. So, if we want to compare between early versus late, and we did not define what is early and what is late, but according to these studies, a systematic review and meta-analysis were done to see which favors from these studies. Is it better to start early or start late? The meta-analysis results in it's relatively to start early dialysis better than to start late dialysis in our patients with acute kidney injury. The included studies were 15 studies. These are, one in the another study, we are going to see that the end result have cut the middle line, so there is no difference between early or late. So the briefer one said there is difference, and early is better. The other meta-analysis said that there is no difference between early or late. Maybe due to the number of the patients, the different types of the studies, the different characteristics of the patient included. He may have included severely ill patients, and the other studies, they were good patients or not severely ill. We don't know. What about the Kiduki guidelines? We should initiate the renal replacement therapy emergency, and this is not rated when there is a life-threatening condition. There is no grade for that. This is an emergency. So if there is no emergency, the other thing is to consider the clinical context of the patient. We should examine our patient, order an ABG, serum creatinine, urine output, and then after the whole picture is complete, a decision is made. Of course, the clinical presentation is a denominator, is a big denominator in this condition. The KDIGO said we should, if we look at the classification of the KDIGO classification, the KDIGO have set stages or guidelines to start treating a patient with acute kidney injury. We are going to see that considering renal replacement therapy, will start from stage 2. Consider renal replacement therapy when the patient is admitted or reached stage 2. So what about stage 2? It's 2 to 3 times increase in the baseline from baseline serum creatinine or urine output less than 0.5 milligram per kg, milli per kg per hour for the last 12 hours. This is an algorithm. I think it's palatable for most of us to how to treat or diagnose, to manage acute kidney injury. You are going to see if there is a life-threatening condition. If there is, we are going to start renal replacement therapy. This is optional. This is logical. If there is no emergency, we are going to optimize the hemodynamics. Optimizing the hemodynamics aims at normalizing the mean arterial blood pressure above 65, and to normalize the CDB and to discontinue any nephrotoxic drug. That's to deal with the risk factors my patient is admitted with. And after good control, we are going to assess the vascular status, the other organ affliction, the severity of the illness, and then we are going to re-examine again. If our patient improves, we are going to reassess. If he do not improve and these parameters are present, we are going to start renal replacement therapy. So again, the management of acute kidney injury is a daily process, and I think it's an hourly process, not a daily process. And the urine output follow-up, I recommend to be hourly, not every 6 hours or 8 hours or 12 hours. In patients with multi-organ failure suffering from acute kidney injury, the urine assessment should be hourly in our patient. And I think this word or this phrase is palatable. Whatever the criteria we use to define early or late, what may be early for one patient could be late for the other, which depend on the patient's comorbidity and clinical course. Which modality? We have too many modalities. We have the intermittent one, which is intermittent hemodialysis and intermittent UF. We have the continuous one, CVDH, hemofiltration or hemodiafiltration or hemodialysis, also continuous ultrafiltration. And we have the hybrid techniques, which combines the intermittent with the continuous one, the sustained low efficient dialysis and sustained low efficient dialysis with filtration. Which one of these modalities we will use with our patients? The intermittent one are relatively inexpensive and available. We can, they are present in most of the institutes. We can modify our time. They modify the fluid overload very rapid. They remove the dialyzer drugs very rapid. they rapidly correct acidosis and the electrolyte imbalance. And of course, due to the short time, there is short exposure for the anticoagulation. So these are all advantages. What about the disadvantages? They cause hemodynamic instability, hypotension, cerebral edema. So the hypotension could result in renal injury. So I could harm my kidney, could result in cardiovascular events, myocardial infarction or cerebral stroke. So, and of course the limited therapy duration, we use 2 hours, 3 hours, 4 hours. So these are disadvantages. What about the continuous techniques? The pros that they are more hemodynamic stable. So there is better renal recovery. We can adjust our volume removal and volume control. The stable intracranial pressure, so there is no cerebral edema. Cytokine removal, we are going to speak about it. But what about the cons? What about the disadvantages? It persists for a long time, so there is a very large need to anticoagulation with its hazards. It's expensive in the machine and in the logistics. It needs trained personnel and immobility issues. My patient will stay on a machine for about 1 day, 18 hours, 24 hours, even 36 hours. So this is a very long duration. Another issue related to the sustained techniques, they found that due to the prolonged duration of the sustained techniques, the patient suffered from hypophosphatemia. This hypophosphatemia, they discovered that it's not just hypophosphatemia to the serum. Even the phosphorus content of the red blood cells will decrease, which will decrease the 2,3-diacyl phosphoglycerate, which is responsible for the binding of our RBCs to oxygenation, which will result in defective oxygenation and could be fatal. So this is one cause for in-hospital deaths and represent a potentially avoidable complication of CRRT. So it's not just hypophosphatemia in the blood, it's hypophosphatemia inside the red blood cells too. So this is a hidden complication which was recently discovered. So it was published in the last year. We have basics of these techniques. The diffusive technique, it's according to the concentration gradient. It's a basic process from the higher concentration to just the lower concentration. And most of the intermittent techniques, intermittent hemodialysis uses the diffusive process. The ultrafiltration means that I want to remove a big amount of fluid with no solute. So I'm going to apply pressure. I'm going to use force. This force will allow me to move large amounts of fluid with a very little amount of solute. These are the different techniques we use: the slow continuous ultrafiltration, the continuous arterial veno-venous hemofiltration, the continuous veno-venous hemodiafiltration. We are going to find that there is another bag added. This bag is the replacement fluid. The replacement fluid is the fluid we replace to the patient instead of the lost fluid we remove from him. And that's why the session continues for a very long duration, and that's why we could maintain, or these sessions do not cause hemodynamic instability. This dialysate is an ultra-pure fluid, and it's added in a specific rate to compensate for the lost fluid in our patients. This dialysate could be added to the patient before the blood goes into the filter, and it's called a pre-dilution. Or it could be added or replaced to the patient with the venous blood returning to the patient, and this is called post-dilution. So the replacement fluid could be put in this line or in this line. If it is here, it's pre-dilution. If it is here, it's post-dilution. What about the uremia control? If you see, this is a continuous veno-venous hemofiltration. It's going to control the uremic toxins in a stable and persistent manner. If we use the daily hemodialysis or the slit, we are going to find that there is fluctuations in the uremic toxins. Fluctuations in the times where there is no dialysis, there is accumulation of uremic toxins, and these toxins will cause harm to the patient. But the continuous techniques will allow me to remove these toxins less at a low rate, but a persistent rate, which could be beneficial to our patients. What about the large molecular removal? We are going to find that the CVH will remove a big amount, but yes, at a low rate, but again at a steady concentration of large molecules like beta-2 microglobulin. We are going to here to compare between the continuous versus the intermittent dialysis. If I have the machine for continuous renal replacement therapy, and I have the machine for intermittent hemodialysis, which modality to use? In this study, they say, showed an increase in the ICU and in-hospital mortality among patients treated with CRRT. We have just said that CRRT is more hemodynamically stable and it's more better to our patients. So why are this group of patients have more mortality, more mortality in the CRRT group? You are going to notice it in here. This is maybe because these patients were the most severely ill. They used the CRRT because they were severely ill, and of course the prognosis were very bad. And for those who are hemodynamically stable, they prefer to use the intermittent technique. And that's why the results were like this. Another one, comparison between the intermittent hemodialysis versus continuous renal replacement therapy. There is no difference between these, no difference. But they compare the total cost. This is an economic study. Of course, the CRRT techniques needed or cost us much more. And in poor countries or developing countries like most of our nations, it's going to be costly. In Egypt, for example, the cost for the CRRT session is 3,500 Egyptian pounds for only one session of the CRRT, and for intermittent hemodialysis it's 140 pounds. This is about 30 times. A very big difference between the cost of the both sessions. What about the outcome if we use intermittent versus CRRT? We have two types of studies here. The end result, there is no mortality difference between therapies. The renal recovery showed no difference between both therapies. And majorities of studies, this is why the results were similar in both. This is the mortality and renal recovery. We are going to see that both studies, or the result at the end, there is no difference between the intermittent and continuous techniques. Again, a systematic review to which type to use. We are going to see the results in here. These are the observational studies, and in here, the other one, these are the observational. These are the observational studies, and these are the randomized control studies. These are the observational above. I didn't include the randomized, but here are the observational and the randomized control studies. In the observational studies, you are going to see a difference. But in the randomized studies, you are going to see no difference. So, the end result, of course, randomized control studies are better or of better significance. The end result, the currently available randomized studies trial do not allow a definitive conclusion on whether choice of the initial modality is associated with greater renal recovery. In my opinion, the best modality to use is the one you could handle well. Of course, it's the one you find in your institute, and if you find all the techniques, it's the one you can handle well. This is comparison between a hybrid technique, which is the slit technique, and the continuous techniques. They say that treatment with a slit was associated with comparable mortality to CRRT. Comparable mortality. There is no difference between the slit or CRRT. And the slit could be readily performed for most of the patients without systematic or regional anticoagulation. Again, there is no difference. In this study, they have tried a different thing. They have tried to do prolonged intermittent session, 10 hours versus 6 hours. This is not a CRRT. It's an intermittent technique, but for a very long duration, 6 versus 10 hours. Of course, the 10 hours caused many complications. Similar between the two groups, but again, the group treated with the sessions of 10 hours were more reflective to clinical measures of hypotension. Prolonged duration on an intermittent technique led to more complications. So I think this is not an important or a valid technique to use. This is one of the most important articles. They have compared the main two things we search: the mortality, the kidney recovery, and our patient survival. If you treat a patient with acute kidney injury, you want to decrease the mortality, get a bit renal recovery, and improve the patient survival. So they have studied in observational trials and in randomized controlled trials to see if there is any difference between CRRT and intermittent therapy. Again, if you are going to see that the result in all of the 3 parameters in both randomized and non-randomized studies or observational studies, there is no clinical significance. No difference between intermittent and continuous techniques or extended daily techniques. What about BD? BD is a line of treatment in patients with acute kidney injury? Yes. This is a study, or not a study, it's a study of the registry. Retrospective study for 301 AKI patients treated with high volume BD between 2004 and 2014. The survival was 40%. About 21 patients suffered from peritonitis, and that's why they were excluded from the study. What about high volume peritoneal dialysis versus hemodialysis? Is hemodialysis better than PD, or PD is better? In the table you are going to find that in mortality they are equal, in renal recovery they are equal, in the duration of treatment and the resolution of AKI there is significance, which was better for the high volume PD. So high volume PD is better than hemodialysis, maybe due to PD doesn't cause hemodynamic instability. You do not deal with blood. You do not get blood from the patient, so that's why it may not cause hemodynamic instability. We should consider the clinical implications of PD like hyperglycemia and protein loss, and that's why we increase the protein intake in patients with PD, the sodium and potassium removal, and the hypercatabolic state. What about the guidelines? The guidelines say we suggest CRRT rather than standard intermittent techniques for hemodynamically unstable. But again, the grading is 2B. Very weak level of evidence. CRRT again, rather than intermittent techniques in patients with acute brain injury or other causes of increased intracranial tension. But again, the grading of the level of evidence is 2B. So, what are we going to use? The vascular access. I think this is clear for all of us. The uncovered, non-tunneled dialysis catheter. We hope we are not going to do dialysis for these patients for a long time. Number 2, it's inserted in the right internal jugular vein, followed by the femoral vein, the left internal jugular vein. The subclavian road should be avoided because it's hazardous. It causes many complications, and above all that, if unlikely our patient developed chronic kidney disease, subclavian stenosis is a result of insertion of this gas. So our patient lost 2 chances in this arm for arteriovenous fistula. Subclavian road is not preferable. The solution, of course, we use the bicarbonate solution. I think in most of the countries, bicarbonate now is the only solution used. Lactate is prohibited or is not in practice again. This is the guidelines. I think bicarbonate is present in every part of the world. The membrane, of course, it's a high flux membrane, biocompatible membrane. The low flux membranes cannot be used with the CRRT. It allows the removal of a large amount of toxins and a large amount of fluids. We said we have diffusion and ultrafiltration. Diffusion removes solutes, and ultrafiltration removes water. So if I want to remove a big amount of solute and a big amount of water, we use another technique which is called convection. Convection is a combination of diffusion and ultrafiltration. A convection is a mechanism which is used in continuous renal replacement therapy, most techniques. The anticoagulation, we have different patterns or different types of anticoagulation. We have the unfractionated heparin, the low molecular heparin, and the citrated dialysate. Citrated dialysate, regional citrated dialysate is better to be used in patients on CRRT to avoid the complications of unfractionated or low molecular weight heparin. Of course, we are going to monitor for the hypocalcemia resulting from the citrated solution. But it's better if we are going to perform long duration. How much therapy? How many sessions? And what are we going to do to our patients? In this study, they have studied two types of chronic continuous renal replacement therapy. The delivered dose less than 35 milli per kg per hour or more than 35 milli per kg per hour. And this is for the continuous dose, continuous techniques. And in the intermittent techniques, they have studied frequency less than 6 sessions per week or more than 6 sessions per week. The result? In this observational study, this is an observational, not randomized control study, the delivered CRRT dose was markedly lower than 35 milli per kg in this arm. The alternate day intermittent techniques for critical patients was uncommon in the participating centers. Uncommon, but uncommon in these centers, not in every part. After adjusting of the multiple variables, there was no beneficial effect of the more intensive arm than the less intensive one. But they found an important issue: shorter ICU stay and the duration of mechanical ventilation was observed in the more intensive group. And this is of significance. You are going to let your patient stay a little time in the ICU and need mechanical ventilation a little time. So for the economics it's better, and for the health of the patient it's better. We recommend delivering an effluent volume of about 20 to 25 milli per kg per hour for patients with CRRT, graded evidence 1A, very strong evidence. This is the cytokine removal. Among critically ill patients receiving renal replacement therapy, the intensive dosing of renal replacement therapy has variable associations with biomarker concentration and no association with renal recovery and mortality. However, the elevated concentrations of inflammatory and apoptotic markers on day 8 of the renal replacement therapy were associated with renal dependence and death. In this article, they say that if we use continuous techniques or the more intense arm, the removal of the cytokines and the inflammatory biomarker could improve the survival and could improve the kidney function. And that's why the cause of the previous study, the intensive arm, they stayed in the ICU better, but there is no difference on the renal recovery. Again, they are all theories and not proved. Provide renal replacement therapy to achieve the goals of electrolyte and acid base and solute balance that will meet the patient's needs. So it's not fixed number, it's not for a fixed duration, and it's not for a fixed number of sessions. Again, it's a clinical evaluation of the patient, and according to my patient, I'm going to determine in each session how much fluid I'm going to remove, what are the most important electrolytes I want to deal with, and to decide when to start, when to terminate. And we are going to study to say when to stop now. So at first, of course, it's logic to say we are going to stop when the kidney functions are improving. If there is improvement in the urine output, and the urine output is the product of the kidney, that means that the kidney is improving, and this is a marker to stop renal replacement therapy. The kidney is improving, so why the need to replace it? So the first indicator to stop dialysis or renal replacement therapy is improvement in urine output. These are studies to assure what I have said. So discontinue when the intrinsic kidney function has recovered to the point that it is adequate to meet the patient needs. Adequate to make my patient going in a good health. The other important issue, it is also important to acknowledge that there may be patients with a futile prognosis, those with many multi-organ failure, and we know that the prognosis is very bad and they are going to eventually die. At this time, we should discuss with the relatives of these patients, and the discontinuation of the renal replacement therapy could be a palatable choice at this time. It's going to be less costly to these relatives, and of course less harming to the patient, and the famous say, let our patients die with dignity. It's a good end of life care. How to improve the outcome? If you have seen the 3 classifications for the acute kidney injury, the life in AKI and KDIGO, they all started with an increase in the serum creatinine of 1.5 times or 2 times. So if my patient is having a serum creatinine of 1.4 and he reached up to 1.8, this is acute kidney disease. He is suffering from a kidney disease now, but I did not discover it. You know that when serum creatinine is increased, or I detect an increase in the serum creatinine, the kidney function have decreased by about 50%. So creatinine is a late marker for acute kidney injury. That's why the term renal angina has appeared. Renal angina, like myocardial infarction, like unstable angina. So we want to make a panel of 1 marker, 2 markers, 3 markers. These markers are going to be used to detect early injury, early acute kidney injury in early phases. And of course, they should be better than serum creatinine in detecting acute kidney injury. They are trying many electrolytes to do this, many biomarkers to do this. This is an important, I think, an interesting slide. It's done in the United Kingdom to see which technique they use for renal replacement therapy in acute kidney injury. The commonest technique is the continuous veno-venous infiltration followed by hemodiafiltration. The dose delivered is between 25 and 35, most of the patients on 35. The most indicator to start the dialysis were the fluid overload and hyperkalemia. And this is all logic. This slide, I inserted it because of this diagram. This is in United Kingdom. I want you to see this slide discussing the referral to a nephrologist. Consulting a nephrologist in treating a case of acute kidney injury. Why? Because most of acute kidney injury patients are ICU'd, in ICU, and they are treated by the intensivists, not by nephrologists. In United Kingdom, you are going to say that sometimes and rarely about 65%. 65% of the patients with acute kidney injury are treated in the United Kingdom, in UK, by the intensivist. They do not let a nephrologist interfere with the case. See, usually it's 17%, always 7.5, never 10%. They do not allow any nephrologist to deal with the case. And I think this is a big issue. To summarize, acute renal failure is not an innocent bystander in ICU. It's a killing bystander. And we must strive to avert acute renal failure. We must ensure adequate dosing according to the patient needs. The choice of renal replacement therapy may not be critical, yes, it's according to the available technique we have. Septic acute renal failure may be a different beast, yes, sepsis has a different modality of action, and of course the severity of the disease is very, it's very severe. Thank you.
Thank you very much, Dr. Ahmed, for this very comprehensive presentation about dialytic support for acute kidney injury. And now it's open for your question. Yes, please.
Merci beaucoup, docteur. C'est une très belle présentation qui est vraiment à jour. En fait, juste faire quelques commentaires. Il disait que nous, on vit. La dernière diapo l'a dit. Nous, on a souvent des insuffisances rénales aiguës dues au sepsis, d'origine infectieuse. Ils arrivent avec des défaillances multi-organiques. Et ces patients, quand ils arrivent, ils passent leur temps, comme vous l'avez dit, aux urgences. On nous appelle 3 ou 4 jours après. Et là, on ne discute plus les indications de la dialyse. On arrive, ils sont anuriques, on le prend automatiquement en dialyse. Et on n'a pas les techniques continues, on fait des hemodialyses intermittentes. Mais ce qu'on fait, c'est des dialyses courtes de 2 heures quotidiennes. L'anticoagulation, on ne le donne pas dû au risque infectieux, mais on fait juste des rinçages de voies. Ils sont instables sur le plan hémodynamique, on fait que des remplissages plus solides. Ils seront salués chaque 15-30 minutes. Donc c'est très difficile. Quand on commence, c'est très difficile. Les techniques, c'est vrai, vous l'avez montré, on demande à quelle intervenante. Mais sachez sur une guerre qu'on a présentée avec notre collègue, c'est 50%. Même si on n'a pas de raison.
Okay, you raised a very important point regarding sepsis. Sepsis is very crucial to be thought when we deal with acute kidney injury cases, because both acute kidney injury and sepsis follow each other like bad twin. And if sepsis develops with an acute kidney injury, mortality increases. And if acute kidney injury occurs on top of sepsis, mortality increases. So should raise our attention to the possibility of infection to guard against its development. But regarding your question about anticoagulation, while we do dialysis for acute kidney injury, we evaluate the patient's status. If there is no clinically manifest bleeding tendency, if there is no hemorrhagic shock, no bleeding, we prefer to use anticoagulation. But if there is high risk of bleeding catastrophe within dialysis, we can follow the technique of anticoagulation-free dialysis by using what we can master. In the period of evolution in this center, we use heparin protamine, so just to anticoagulate the extra corporeal circuit. So heparin is given when before the blood pump, and protamine is injected before the blood return to the patient. So by this way, we stop the risk of heparin by giving protamine. We mastered this technique, but nowadays we stopped it, and our nurses and our residents are clever in using just to flush, inspecting the venous chamber meticulously, and adding the flush of normal saline and quantity, and add the quantity to the net ultrafiltration. So your comments are very valid and to put in mind. And I add my voice to Dr. Ahmed that we should master what's available, because he demonstrated that there is no difference between intermittent, slow continuous therapy, so master what you have. And this is what we do here. Even if the patient is hypotensive and acute kidney injury, but there is necessity of dialysis, we support the hemodynamic circulation and continuing SLED. Nowadays, in this center, we have the slow continuous therapy machine, so we can dedicate it for these patients with hemodynamic compromise, or in the presence of severe hyponatremia, as I mentioned yesterday. Yes? Do you have questions?
Merci pour votre exposé. C'est un exposé qui est complet, qui a bon, deux techniques qui posent problème jusqu'aujourd'hui sur le plan scientifique. Je pense que le professeur Chicha a fait un peu le tour de la question. Jusqu'aujourd'hui, dans les pays développés et chez les anglo-saxons, il n'y a pas de consensus concernant quelle méthode utiliser, qu'elle soit continue ou qu'elle soit conventionnelle. Par contre, ce qui est sûr, c'est que les techniques continues coûtent beaucoup d'argent, consomment du personnel, pour un alignement du malade qui est dur et pour un résultat qui est mitigé en fait par rapport aux techniques conventionnelles. Moi je pense aujourd'hui, chez nous en Afrique noire, le défi c'est plus de raccourcir le délai du diagnostic de la maladie et de raccourcir le délai de consultation du malade. Parce que si je prends le cas de notre pays, nous avons remarqué que la plupart du temps, les malades transitent par les praticiens, ils font les cliniques privées, ils font les hôpitaux, ils consultent les médecins généralistes, et ce n'est que quand le malade est en coma, ou quand les gens sont impuissants, qu'on appelle le néphrologue. Après une semaine de retard, donc les gens attendent à ce qu'on fasse des miracles, chose qu'on ne peut pas faire. La dialyse ne peut pas être un traitement de miracle. La deuxième des choses, on est aussi sujet au manque de personnel. Par exemple, chez nous, dans notre pays, il n'y a que 3 néphrologues pour 14 millions d'habitants. C'est aussi un grand problème. Maintenant, concernant la prise en charge des maladies en elles-mêmes, moi je pense que le défi c'est par rapport à l'étiologie de la néphropathie. Quand par exemple c'est une nécrose tubulaire, secondaire à une infection qui n'est pas compliquée, quand c'est par exemple une nécrose tubulaire d'origine par exemple toxique, médicamenteuse, le défi n'est pas aussi grand que si par exemple c'est un malade VIH qui fait une HIV associée de néphropathie avec une défaillance multiviscérale qui nécessite plusieurs spécialités et qui nécessite une réanimation médicale. Moi je pense que les problèmes il faut les situer dans le contexte. Sinon pour le reste, je donnerai le cas par exemple, ça ne fait même pas un mois qu'on a managé une patiente enceinte de 32 ans qui a été référée chez nous parce qu'elle a fait un coma sur une pyélonéphrite grave associée à la prise de médicaments toxiques. Donc elle était en coma. Nous l'avons, comme mon confrère l'a dit, nous l'avons prise. D'abord équilibre dynamique, des séances de dialyse, on a enlevé toutes les drogues qui étaient toxiques. Par la suite, des séances quotidiennes d'hémodialyse en présence des gynécologues. Et donc il y avait un haut risque pour l'enfant, pour la maman, mais notre succès c'est qu'avec la simple hémodialyse conventionnelle, en manageant les pompes, le sodium, la conductivité, les bicarbonates, on est arrivé à sauver la maman et l'enfant. Et on a pu la sortir de dialyse avec un chiffre de créatinine qui à l'entrée était à 1400 micromoles. Elle est sortie avec à peu près 50 micromoles. Donc je confirme ce que vous avez dit, mais pour nous, les techniques continues, on les a fait, mais on reste avec les techniques conventionnelles qu'on maîtrise, et le défi, je pense qu'il est un peu ailleurs par rapport au pays anglo-saxon. Merci.
Thank you for your comment. I think it's a common problem in all developing countries, the availability of the options of the logistics, the machines, even in Egypt. Not so many centers have the continuous renal techniques or have doctors and nurse staff who are trained to use these techniques. It's present here in Mansoura University, Mansoura Urology and Referral Center, and in Mansoura University Hospital we have another machine or 2 machines. In some of the hospitals in the Egyptian Ministry of Health, they have this machine, but they don't use it. They cannot master using it. So what I've said is correct in all of the countries. In most of the developing countries, there is some shortage of the nephrologists. In Egypt, we have too many nephrologists. By the way, we have many nephrologists, but there is, I think, lack of knowledge, lack of experience of how to deal with the cases, lack of knowledge between doctors themselves to refer to a nephrologist. Of course, shortage of nephrologists is a catastrophe we should deal with, and we should find a solution for it. You said all the three nephrologists in the country for 14 million individuals, and this is a very big number of nephrologists.
But the management of acute kidney injury in many countries is for other specialties. So we should go to other specialties. Even there are in many CME courses nephrology for non-nephrologists. So we should educate them and to put them on the track. I just want to add two short comments regarding early dialysis in acute kidney injury in rifle or AKI or even KDIGO stage 2. I don't agree at all. I agree about the clinical indications, volume overload, hyperkalemia. So we leave dialysis until there is clinical indication. But we shouldn't be late as coma. As coma is not an indication for dialysis nowadays because it's too late. So it is neither early nor late. It is on-time dialysis for the presence of clinical complication. To the extent that in the management of acute kidney injury, we shouldn't put diuretics just to postpone dialysis. If there is volume overload, dialysis and ultrafiltration is needed because overload is associated with high mortality. Regarding peritoneal dialysis, if you have peritoneal dialysis, acute PD I mean, you can use it so long as there is no hypercatabolic process. So in the presence of severe hyperkalemia, hyperphosphatemia, hypercatabolism, peritoneal dialysis is very poor in efficiency. But if you have the kit for acute PD, it's okay to use this modality. So use what is available and educate. We should educate ourselves and educate other specialties how to do. Even at Harvard Medical School, when I visited this place since 9 years, 8 years, since 8 years, the dialysis in the ICU is governed and controlled by intensivists. And the nephrologist just came to write prescription and they go around. And they have all facilities, but for acute kidney injury related dialysis, they select CRRT, only one modality. So it is not luxurious to know everything, but when you have even one modality, if we master it, this will be perfect for our patients.
I totally agree with Dr. Hussein. The shortage could be treated with dealing with other doctors, especially intensivists. They see the patient before we see it. So we should teach the intensivists how to deal. They are going to solve most of this problem.
And as we are living in Africa, in Egypt we have many nephrologists, so we can we can help with this. Yeah. Okay. Yes. Please.
Thank you for the very informative presentation, and I like the fact that you emphasized on the urinary output as a way of detecting, diagnosing failure, and the teamwork. Because recently I received a patient who had been referred from a peripheral facility. Most of our cases of acute renal failure coming from obstetric complications. So this was a lady who had delivered, difficult delivery, had bled a lot and had stayed for 4 days without passing urine, but it was not reported. So because she was conscious and she was talking, everybody thought it was okay. So I would like to know regarding discontinuation of renal replacement therapy for acute kidney injury. What is the practice here with regards to the volume of output? What cutoff are you using so that you say now this is restored or recovered? And what is the role of diuretics? And how would you know whether it is output because of diuretics or is it spontaneous output that you use? Thank you.
Thank you for your question. Regarding your first question, which the volume of urine at which I should discontinue renal replacement therapy, this is correct. You are going to see in these studies. This is the starting of renal replacement therapy. You are going to see for the urine output. They started for